Thank you, sir. So I'll start. So today the topic allotted to me is systemic therapy in brain mets, which is a very vast topic, and I know that I won't be able to cover the entire range of brain metastasis in various tumors. So just some few basic concepts, and I'll use lung cancer as the main example, so that because this is a lung cancer master class. So through that we'll just go through the basic issues with systemic therapy and how we approach patients with brain mets and plan systemic therapy in them. So one is what are our targets? Issues in brain systemic therapy are slightly different from the rest of the body. We know the blood-brain barrier limits the entry of a lot of our drugs into the brain, and also issues in interpretation of data. So now with newer agents and targeted therapy, a lot of our trials include patients with brain mets or focus on brain metastasis and intracranial responses. But in the past, there was very limited data, so that was an issue then. And how can we improve delivery into the brain? It's not just for chemotherapy, but targeted therapy. So some of the challenges in treating brain metastasis with systemic therapy mainly include the biological issues, that is the blood-brain barrier. And the second is the resistant clone. So because of the blood-brain barrier, whatever agents that we usually use, which are chemotherapy or maybe early targeted agents which have limited CNS penetration, might lead to the resistant clones developing in the brain, which they're relatively protected from the systemic therapeutic agents in the circulation. And again, I had discussed about the molecular data. Sometimes, as sir has discussed in detail about the biopsies and the challenges in the neurosurgical managing patients and operating them with brain mets, we may not have the molecular data for all our brain metastasis patients. Often it is treated with systemic therapy or radiation based on radiology alone. So we don't know whether these brain metastases have a same molecular profile, whether they vary in the disease biology, and this again influences the outcomes. So let's start with lung cancer. So lung cancer is one of the cancers where brain mets is a common, it's a common site of metastasis. And we know that many studies, this is one of them, that driver mutated lung cancers, that is those who have any of the driver mutations such as EGFR, ALK, ROS, have higher incidence of brain mets. And multiple studies have evaluated different approaches to treat brain mets, including targeting them with TKIs, using radiation with some chemotherapy agents known to have CNS activity like temozolomide, and a targeted therapy with radiation. But all these older studies had limited success. So we divide our main approach to patients with brain mets into either driver mutated or non-driver mutated, because that is now with the availability of new therapy that actually defines the outcomes and the management. So in short, we know non-driver mutated lung cancer patients. So what we look at is if the patient has a brain mets at baseline, it depends on the fitness and the performance status of the patient and what type of histology he has. So in a non-small cell lung cancer patient, if the patient has brain metastasis, often they receive WBRT, and then we start off with systemic chemotherapy. Usually chemotherapy is not given along with WBRT, neither are target agents because of the toxicity issues. And then we go ahead with the systemic therapy. Often now with newer SRS and other options coming, the number and the size of brain mets decide what radiotherapy option will be suitable. So that will be covered in the next session by Dr. Anil. In case the patient progresses on the standard therapy, that is commonly chemotherapy plus or minus immunotherapy based on what the patient is receiving, then again, the brain, depending on the number and size and the symptoms and the performance of the patient, will either receive radiation and then go on to the next line of systemic therapy, whichever is appropriate. One thing to remember is if patients have brain mets and very poor performance status, or they are unfit to receive any further systemic therapy, sometimes best supportive care might be the only treatment option, especially in those who don't have any driver mutations. So brain mets in patients with oncogenic driver mutations, or how do we approach them? So now in this current era, systemic therapy is preferred in a patient if you have a known driver mutation rather than the local therapies, especially radiation. In the past, it was reflex to send the patient for radiation and then start chemotherapy. That is because we have new drugs which have very good intracranial penetration and activity. So they can target brain mets, as well as in higher doses, many of them target the leptomeningeal disease as well. Because of the efficacy of these drugs, now the survival of patients has gone from chemotherapy, which has usually from 8 to 10 months overall survival, to patients with ALK positive on alectinib living up to 6 years. So we know that all the side effects of the systemic therapy, whether it is in the intracranial or extracranial, you're going to see more of these as patients are going to live long enough to get these toxicities. And one of the important toxicities is cognitive deficits from previous local therapies. So patients who receive WBRT, and we see a large number of them because these patients live longer, they receive sequential therapy, one TKI after another. And as time goes by, you can see all the toxicities of the previous radiation. And some limited observational data suggested that if you treat them with targeted therapy and radiation therapy, with targeted therapy, there's no extra advantage of giving that radiation. So there's so that is why now we prefer, based on the size, number, site, and the symptoms of the patient. If the patient is asymptomatic and there are no mets at the critical site, we go ahead with systemic therapy with the targeted drug rather than going ahead with radiation as the first treatment. So this is just a table to look at the last row. So you look at this CNS penetration of CSF and blood, and this is an EGFR positive lung cancers. Now the main problem with us in all the targeted therapy is how much of the drug level reaches the brain as compared to the plasma, and that makes often the brain often the main site of failure when patients progress. So you can see the first generation is 0.03 times the CSF plasma ratio, with erlotinib, then 0.01x, that is CSF plasma ratio for geftinib. But if you look at the osimertinib, the brain plasma ratio, you can see it's 2 times of plasma, and that is why osimertinib has good CNS activity and is effective in CNS metastasis. But again, if you have all these options in an EGFR positive lung cancer, what will you do? If do you treat a patient with the first generation TKI, second generation, third generation, or a combination TKI chemo VEGF therapies? So a large part of this decision making is based on the CNS activity of these drugs, and that is why osimertinib is the preferred first line agent in patients who have lung cancer with EGFR sensitizing mutations. It's because of the CNS activity, and both in the second line and the first line, both the studies showed there was a huge difference in the CNS activity, and that in turn influenced the survival as well. So patients who had CNS mets had poor overall survival also. So you can see the green is osimertinib, which was better than the first and second generation. The second generation, afatinib and dacometinib, have some CNS activity, but the main study which studied afatinib in phase 3 setting was the Archer study, which did not include brain mets. So it is a little difficult to place it in patients who have had brain mets, and how will they respond to it. And TKI plus chemo, I will discuss later. The activity in the brain mets per se was not reported in both these studies, but it did not have the benefit was not as much in patients with brain mets as with those without brain mets. And TKI and anti-VEGF, there was no PFS benefit reported if the patient had asymptomatic mets. That is the studies with erlotinib and bevacizumab and erlotinib and ramucirumab. So let's go to osimertinib. It is the drug in EGFR positive lung cancers, which we use as standard of care in the first line setting. And in the first line setting, suppose you have a newly diagnosed patient. If you look at the boxes in the first row, there are 2 columns mainly. One was the patients who had baseline mets. So they had mets at the time of enrolling in this FLORA study, and one who did not have mets, and they then developed during the course of treatment. So if you look at the comparison between osimertinib and the standard EGFR, here standard EGFR was erlotinib and gefitinib, so the first generation TKIs, and you can see it is almost more than double the number of patients had CNS progression. And it was not just in the number of new lesions, the non-targeted lesions all increased, then they were nearly double in all the types. And if you look at the patients who had also no known baseline meds, even there it is double the number of patients had CNS progression. So which shows that osimertinib has a significant impact on the CNS progression. It controls the brain lesions, it prevents new lesions from coming, and even progression of the old lesions. This AURA-3 is the study which actually came before FLAURA-3, and this studied osimertinib in patients with the EGFR T790M mutation, which is a resistant mutation to the first generation TKIs. And you can see the difference. The progression-free survival in the patients who had brain metastasis and got osimertinib as compared to those who got chemotherapy, because that time chemotherapy was the standard second line if you had to progress on erlotinib or gefitinib. And the survival was, the progression-free survival was doubled. It was 11.7 as compared to just 5.6 months with chemotherapy. And again, you can look at the patients who had baseline METs. They survived, progression-free survival for those patients was 8.5 months, and it was only 4 months with chemotherapy. And for those who had no brain mets at baseline, the progression-free survival was around 11 months, and again 5.6 months with chemotherapy. So osimertinib is the drug of choice amongst all the EGFR drugs when you come to patients with brain mets. So you can see this is the progression-free survival for the patients with CNS mets, and see the difference in the progression. So those with osimertinib is the blue line, and the red line is those who received platinum and pemetrexed. And you can see the significant difference the patients had in the progression-free survival in the brain. And this again shows that osimertinib helped all subgroups, but to remember, patients with CNS mets also had a significant benefit. This is not seen in other trials with other agents. So this was the disease control rate. So the patients who had CNS disease control, and in the patients who received osimertinib either in the first line or in the second line, and patients who had received TKI, there's a significant difference, almost 20 to 30%. So important is in our setting, current setting, osimertinib is the TKI which has CNS activity. It has longer PFS. It has better objective response rates. Whether you are taking it in first line setting or second line setting in a EGFR mutated lung cancer, you get good responses. You get responses as early as 6 weeks in patients who have CNS met. So that also justifies us not treating these patients with radiation and going ahead with systemic therapy, because you can see responses as early as 6 weeks. Irrespective of previous radiation, responses were noted. And of course, that patients with leptomeningeal mets also had benefit. And we know that we use a higher dose of osimertinib in our clinical practice today of 160 milligrams to treat patients with leptomeningeal metastasis. So this was a slide which from our study, which combining gefitinib with pemetrexed carboplatin, and just the red arrow to highlight that though all the subgroups had benefit with the combination, you can see the ones with brain mets benefited less. And that is because both the targets, that is both the agents, gefitinib and chemotherapy, have a minimal penetration into the CNS. So the next question is, if we are looking at EGFR mutated lung cancer, and we know that survivals go up to 38 months, 39 months in the first line with first line osimertinib, is there something for patients beyond osimertinib? What happens once they progress beyond osimertinib? Because now the older generation TKIs are going out of vogue. So there are newer TKIs which are being developed for patients who have progressed post osimertinib with better CNS penetration. So the ratio which I had shown in the table before of osimertinib blood to plasma to brain ratio, where it was 2 for osimertinib and 0.01 for the other drugs, in lazertinib it goes up to 7 and 7.9. And this is a image which I've taken from the paper which described this phase 1 data for lazertinib, and you can see the dramatic responses, not just the extracranial, but including the intracranial responses. So lazertinib is not yet approved as standard of care, but it is in multiple clinical trials in multiple settings. So it is being studied. There are trials in our center as well, where it's being studied in patients with newly diagnosed EGFR 19 deletion and L858R, as well as those who have exon 20 insertions in the EGFR, in combination with an anti-EGFR monoclonal antibody, which is amivantamab. This was one of the early studies which studied this drug, and this was again for the standard common mutations, 19 deletion or L858R. And they had around 37% with brain mets. And they had a significant benefit with the use of osimertinib, with use of lazertinib. And even in the limited patients who are enrolled in clinical trials, we have seen a large number of patients with brain mets doing very well with a near complete response to patients to this drug. Now it remains to be proven, like the overall survival and other outcomes need to be proven before it is approved for standard therapy. So just to summarize, there are multiple options for treatment of EGFR lung cancer today. It's going to probably change in the next few years because more and more drugs with CNS activity is entering the picture. Very soon, probably the older first generation drugs might be reserved for only those who are unfit for the newer drugs. And we are not going to use them as standard of care in the next 5 to 10 years. So if the patient again has progressed, we always look at what kind of progression it is, whether it is only a local progression at a limited site, like an oligo progression at a single site like bone or brain, or whether he has multiple site progressions, and that decides our further treatment. So if there is no other extracranial progression and only there is a single brain met which has progressed, I mean, he has progressed in the brain, then it depends on whether the patient can receive osimertinib or any good subsequent TKI like lazertinib or enroll in a trial, and which can act against the CNS met. If they cannot, then we obviously have to refer them for radiation and then continue with whatever therapy they can take, which usually is chemotherapy. And if they can receive osimertinib, then we should give them osimertinib. And this thing which I've added is, if there are newer drugs which have superior activity other than osimertinib and patient has progressed on osimertinib, we should offer these patients an option to participate in these drug trials. So ALK positive lung cancer, we know again, is one of the driver mutated lung cancers which have a high incidence of brain metastasis, and that is one of the important sites of failure. So again, just like osimertinib, we generally prefer the higher generation ALK TKIs, ceritinib, alectinib, or brigatinib. But in practice, we know that all patients do not get the these newer ALK TKIs. Crizotinib has very minimal CNS penetration, and the main failure for crizotinib treatment is the brain. So this is ceritinib, which has some modest CNS activity, not as good as alectinib, brigatinib, or lorlatinib, which has the best CNS activity. And there are response rates. So if you had to compare patients who had received ceritinib versus chemotherapy, and they had measurable brain mets, and patients who had ceritinib had a 73% intracranial response as compared to 27% with chemotherapy. And they, of course, lived longer. They lived almost for 11 months as compared to 6.7 months with chemo. And this was another one which assessed patients with brain mets. And again, they saw that objective response rates were 59% with the ceritinib. So this drug, alectinib and brigatinib and lorlatinib, these are the next, these are second generation TKIs. Lorlatinib is a third generation or a next generation TKI. They have the best CNS activity, and they are alectinib, brigatinib is currently recommended or the preferred options for first-line treatment. Unfortunately, not all our patients have access. And if you look at the benefit, not just the overall survival being nearly up to 6 years, but if you look at patients who had brain mets in patients with CNS mets and ALK mutated patients who received alectinib in the first line, the intracranial response rate was 81 versus 50%. That was a 30% increase in the intracranial responses, and they were durable. So the control of the intracranial mets, it lasted for almost 1.5 years. So that is one important thing, not just in the global population and even in the JALEX study, there was a significant improvement with the use of alectinib, which is much, much more than what is seen with ceritinib, which is only about 11 months PFS. Here it goes beyond that. So brigatinib also has very good CNS activity, and even it is one of the choices for initial treatment. So when they looked at the patients in ALTA study, where they were newly diagnosed patients, only 9% with brigatinib had CNS progression as compared to almost 20% with crizotinib. Now, there's a big debate with the data of this Crown study of whether you should use lorlatinib because it's the best CNS activity, the most potent TKIs for ALK mutated lung cancers in the first line setting or not. Some people are very strongly for this. And yesterday there were 2 panel discussions on the same. So whether you should use it in the first line or second line is a debate because of multiple issues, but lorlatinib has superior CNS progression. And if you look at the intracranial responders, suppose you had metastasis, 66% of patients with brain mets had a response. Out of that, 61% of those patients, that means out of 25 patients who had brain mets at baseline, 23% had a CR. And this is the interim analysis of the Crown study. So you can imagine that, so you basically, there are no brain mets in 61% of the patients who receive the drug. So they clear almost all the brain mets, and the median basically duration of response is not estimated, means it has not yet reached. So probably on longer follow-up, we'll know what is the CNS response. So this is what the same table was showing. The patients who had brain mets and they did not progress. So this is the 33-month up to 33 months follow-up. So they didn't progress, and those who received crizotinib, you can see they had a CNS progression. This is a progression in the brain, so not the overall progression. And you can see how rapidly patients who receive crizotinib progress. And again, here, this is the same subgroup analysis of the same study. And again, just to show that the brain mets patients, how the magnitude of benefit they received by using lorlatinib. So what happens to patients who progress on first-line crizotinib, and what is the evidence? So again, all these three drugs have strong evidence for patients. They were in earlier, some of them were in early phase studies, and alectinib has been studied in a phase 3 study. And in this study, if you look at patients who received alectinib after chemotherapy or crizotinib, 54% had a response to alectinib, and those who had chemo or crizotinib, it was 0%. Similarly, you can look at the data for brigatinib and lorlatinib. So we know now in ALK positive lung cancer, obviously in the first line setting, if we can, we do give an agent with superior CNS penetration. Crizotinib is not the ideal choice in this setting. And on progression, all the second generation and the third generation agents have activity, with lorlatinib with the best activity. But we all know that lorlatinib has its limitations in terms of toxicity, especially with neurocognitive toxicities like having cognitive dysfunction, abnormal behavior, hallucinations, and which can be challenging, especially in patients who are elderly. So that is one of the dose limiting factors. Often with dose reductions from 100 to maybe 50 milligrams per day, it comes down, but that is a challenge. Other metabolic side effects like dyslipidemia are also a challenge. So that limits its use in the first line setting. So with ROS1 positive non-small cell cancer, again, we in our clinical practice use crizotinib for the lack of access to other drugs. Ceritinib is also used in the treatment of ROS1 positive non-small cell lung cancer. But most importantly, crizotinib and ceritinib I have not highlighted because of the limited CNS activity. Entrectinib is a drug which is also an NTRK, pan-NTRK, as well as a ROS inhibitor, which is used. And in these pooled phase 1 studies, which they pooled the data of a small number of patients, they saw that an objective response rate in the brain was nearly 80%. And the brain mets, that is the progression of the brain mets, the median was 12 months. So median intracranial PFS was 1 year, which is remarkable. Usually we know patients with brain mets have progression very fast, especially on crizotinib and ceritinib. So entrectinib is one of the options. Repotrectinib is another pan-NTRK inhibitor which has activity against ROS. It is still under trials, and the interim data is promising, but this has not been completed. Lorlatinib is used in patients who progress on crizotinib, and again, lorlatinib in these small studies that were done in ROS1 mutated lung cancer shows good activity. Both in the patients who did not receive any prior treatment, that was, if you had not received any crizotinib, you still had an intracranial response rate of 63%. Even if you failed crizotinib, 51% of the patients had a benefit. Similarly, new drugs for MET, both tepotinib and capmatinib, have CNS activity. The CNS activity of capmatinib is better demonstrated in the study, but both these drugs act against brain MET. So they are, if you have a patient with a MET exon 14 skip mutation and has brain METs, you would choose capmatinib if accessible as the first line of treatment rather than local therapy like radiation and surgery. So just to summarize all the data which from lung cancer and driver mutated lung cancer, simple is, if you don't have driver mutation, we are limited with chemotherapy and immunotherapy, which we know has limited brain penetration. In the past, very old studies in the early 2000s, people used chemotherapy agents with some CNS penetration like temozolomide, and they tried to see if temozolomide had improved survival as compared to RT alone, because temozolomide, of course, is used in primary brain tumors. There was no benefit. So for driver mutation negative patients, depending on the number, the size, the location, and the symptoms, the decision for radiation will be taken by the radiation oncologist if the patient needs urgent radiation. And then we go on with our systemic therapy, chemotherapy, and immunotherapy based on the axis. If the patient has driver mutation positive and is asymptomatic, targeted therapy is the way to go. Don't subject these patients to unnecessary whole brain radiation if they have access to a good good therapy, because what is going to happen is you're going to have a patient who's going to live longer but is going to be a vegetable. So that is not a kind of a scenario you want. We see radiation necrosis in a large number of patients. The safety of TKIs with radiation is not known. Some small study reports say erlotinib may be given with TKIs, but by and large, we don't give TKIs during whole brain radiation. If at all the patient needs it, we wait for the radiation to get completed and then start the TKI. There is no data clear on what you do if patients have received stereotactic radiosurgery. So some people also, there are multiple studies, but there is no clear recommendation. So there also you wait till SRS is over and start the TKI to avoid any neurocognitive dysfunction. Treating radiation necrosis is very difficult. Most patients, they become steroid dependent, or they end up going on bevacizumab and they don't do well. Their quality of life deteriorates very rapidly. So you may have a patient who's living for 3 years with bad quality of life. So that is not what we want. Of course, even if you have a driver mutation and you're a symptomatic patient with raised ICT herniation, those patients might require neurosurgical intervention. Also now for oligometastatic driver mutated lung cancer, which has just one brain met, we do offer patients an option to get a neurosurgery done and remove the treatment and try to treat it with a curative intent rather than just a palliative intent. Again, recurrent brain mets, if there is a drug which acts in the CNS in the second line, third line, you should choose it. If you don't have any other option, then you have to refer the patient for radiation. And if you're driver mutation negative, again, systemic therapy and radiation. So I just put melanoma, but I won't go into details. Just to show, similar to lung cancer, melanoma also, they have evaluated the role of targeted therapy. So especially V600E or K are common mutations in melanoma. So this was a phase 2 study. And what it ultimately showed is there is activity of these dabrafenib. There are some studies phase 2 with vemurafenib as well. They do act in patients who have brain mets in melanoma. They control the brain mets, but overall the outcomes are still not as good as those who do not have brain mets. So there is some activity, but it's not as effective. So more promising data was from this Checkmate 204 trial, which used nivolumab and ipilimumab. We know in metastatic melanoma, we use it as the first line of treatment. And this combination showed a significant intracranial clinical benefit. So they defined it as patients who had stable disease or CR or PR, and the stable disease had to be for at least 6 months. This was the way they defined the benefit, and 57% of patients had benefit and 26% had a complete response. So though targeted therapy has data in melanoma, the best data for intracranial control from systemic therapy so far has been from Nivo and IPI, and maybe more data will come in the future. So if you look at this flowchart, if they are systemic therapy naive, even based on the BRAF V600 status, even though they have a mutation, they would prefer immunotherapy in the first line and then go to a BRAF inhibitor later. So there are some unanswered questions, and this is a small part where I wanted to highlight what are the challenges of systemic therapy. There is so many trials. I have not included breast cancer, RCC, and other cancers because the volume of there is so much of data. But just to put into perspective, most of our problems are because of one is genetic heterogeneity. Second is, are there any brain met specific drivers? We know in general driver mutations have higher brain mets, but are there any specific mutations or in those subtypes of driver mutations which have a higher incidence of brain mets? Or are the brain mets molecularly different from the systemic mets? That is one thing which is not clearly established. And whether just treating the CNS mets individually will change our clinical outcomes, which means that suppose a patient has lung cancer with the brain met, you treat the brain met based on the molecular profiling of the brain met lesion. Will it change our outcomes? We do not know. These are unanswered questions, not just in lung, but in other malignancies as well. And again, what is the immune microenvironment? So like in melanoma, they showed that the targeted drug had responses, but the immunotherapy did better. So is immune system like how we know in immune checkpoint inhibitors, the microenvironment plays a role. And that is why we do the PDL1 testing and we look at the tumor cell, the immune cells, and the various scores for various drugs. So does this apply to brain tumors as well? Does the immune microenvironment evolve in the CNS tumors and contribute to CNS progression, which we are not able to target well? So this lady called Priscilla Brastiano, she does a lot of work on brain mets. And this is one of the papers published by her where she did genomic whole exome sequencing for brain metastasis to look for a potential therapeutic target. So what she showed is they took 86 brain metastasis samples, primary tumors, and the normal tissue, and they did extensive exome genomic analysis. And what she realized is that during this, that often the brain metastases do not have the same metastasis like the primary. So I'll just show you this is one of the charts she has made, which shows the metastasis and evolution with time. So this is the time point where the patient got diagnosed. This patient had RCC. So these were the MET seen. So VHL, TET2, and then this is over time. So after the patient underwent surgery and RF ablation, then he had progression, bevacizumab was given, and then over time. So this time frame is 5 years. And then she also showed how the brain met evolved and additional mutations were seen. P10, SETD2 were noted. So she has in her the 86 samples that she sequenced, this is the evolution of brain mets, and she realized that the brain mets at diagnosis or the genomic profile at diagnosis need not be the same as the brain mets that appear later. So there is a difference. And she has now, this is a study which is ongoing. This is a national biomarker driven trial in brain metastasis. It's by the NCI in the US. And they have identified 3 markers they want to basically evaluate. One is the CDK pathway, one is the PIK3 pathway, and the NTRK ROS pathway. So patients who have measurable CNS disease, progressing brain mets, and they should have some tissue, either brain mets or extracranial sites. And this trial will sequence these patients and accordingly give them a CDK inhibitor based or a PI3K inhibitor if they have a PIK3 mutation, or a lung, if it's lung and they have an NTRK ROS, they will treat it accordingly. So this is one of the studies which is looking at biomarker driven treatment of the brain mets alone, of the brain mets in particular. Now, there has been some studies of how you disrupt blood-brain barrier and try to give better penetration and improve outcomes. So there were 3 approaches used. One is physical disruption, using like giving a hypoosmolar agent like mannitol, using some drugs, chemical disruption, biological disruption. And one of the some of the agents that was studied quite extensively were efflux blockers. That is, we all know that the glycoprotein PGP is an efflux pump, and it pushes drugs out of the cell, and this is very active in the CNS. And they realized that certain normal drugs like verapamil, quinidine, and cyclosporin had a inhibitory effect on this protein, and it could probably increase the CNS penetration of certain drugs. So they tried multiple drugs. They developed 2nd generation and 3rd generation drugs. All these trials failed. One thing is they did not have any benefit in terms of outcomes, and second is a lot of these drugs increase CNS toxicity like ataxia, and all the trials were held and none of them are successful. So these strategies did not work. There are some strategies which improve drug penetrability, like putting a carrier mediated tagging, nanoparticle drugs, which aim to improve the penetrability. So to conclude, one thing is targeted therapy is important in brain mets management. Like people in the West are doing, we probably need well-designed studies where they focus on only the brain metastasis and the evolution of the mutations in them, and more molecular profiling of brain mets is required, whether it is lung cancer, breast cancer, or RCC, or any of the cancers which have a common site of brain mets. So I'll end my talk. Thank you for the patient listening. So usually for TKI, we wait for at least 7 to 10 days, and for chemotherapy also 10 to 14 days, and also depends on the patient's PS. Sometimes if the patient has very large volume extracranial disease and is symptomatic breathless, we may not wait for that long, wait for 4 to 5 days and start treatment.
And ma'am, repeat imaging after we have given TKI.
So generally we do, if the patient has known brain mets, we do every 3 to 4 months. And then at the same time, we do the extracranial imaging. For asymptomatic patients without baseline brain mets in non-small cell cancer, we don't keep repeatedly doing follow-up scans. We have started doing everybody's scan at baseline now for non-small cell cancer, which we were not doing in the past to detect brain mets. So because we can offer better drugs to them at baseline.
Thank you, ma'am.